All right, so today we're talking about psychiatry history and counseling station. Well, more of psychiatry, actually. All right, so for psychiatry, you expect cases like depression, psychosis, suicide risk assessment, okay? Now, one thing with psychiatry is, and you must never miss in any exam, any OSCE, and even in real life, is the fact that patients with mental illness sometimes can, harm themselves or sometimes even hurt other people, okay? So it's really important that you look out for suicide in every psychiatry case, well, except your eating disorders, obviously, like but even bulimia or even anorexia, sometimes they do have low moods, they are being bullied. So to be fair, I would say that, in those your psychiatric cases, always, check for suicide risk. Now, my next slide is, does anybody know? So can we discuss, let's just talk quickly about depression. What are the symptoms we expect from a depression case?
Poor eye contact.
Poor eye contact, okay. Is anybody familiar with low moods? Yes, thank you. Are we familiar with
mnemonic?
Sorry, go ahead, please.
Epilepsy is a mnemonic, I think. Sleep.
Yes,
low energy.
SIGECAPS.
Appetite is low.
Yes.
Yeah.
So let's go over it, right? So our patients with lack of interest, anhedonia, somebody posted that in the group as well, right? So your patient is going to have sleep issues. Now, if your patient has sleep issues, you need to explore it. So tell me more about it, okay? So you need to ask them, what is your bedtime routine, right? So you need to ask the patient to tell you their bedtime routine. Then the sleep issues, you cannot just assume what the sleep issues is. Is it problems with falling asleep? Is it problems staying asleep? Or waking up frequently? Okay, so you need to explore. You need to find out. So if your patient says, oh, doctor, I'm not able to sleep, don't just go to the next question. Are you irritable? No, you need to explore what the sleep issue is. So first, can you tell me about your bedtime routine? Then, do you have problems? When you say you have problems falling asleep, when you say you have problems with sleep, is it falling asleep? Is it staying asleep? Or is it waking up frequently? You want to know. You want to have an idea. You also want to know how many hours of sleep do they get at night, okay? So you definitely want to explore it further. So again, it's not enough to ask the questions. You always have to explore. So from last week, we know that majority of symptoms, we will explore them, okay? So after sleep, we know that the I is irritability, okay? So do you find yourself irritable? Or the patient complaint might be, oh, my husband and my children are complaining about me, Then guilt. Do you have any feelings of guilt? Okay. Then energy. How would you rate your energy level? Okay. Are you able to do what you normally do on a good day? Are you able to do your daily routine? Okay. So you want to find out. Okay. Are you able to do the things that you normally do? Are you able to carry out your daily routine? Concentration. Do you have any problems concentrating, whether at home, whether at work? You want to ask those things. Okay. So SIGECAPS. Anhedonia, have you lost interest in the things that you normally enjoy doing? Okay, so, or you could ask, what are your hobbies? Do you still enjoy them? Again, there are so many ways to do the same thing. Okay, but because of time, you could just go straight and be like, have you lost interest in the things that you normally enjoy doing? Then this psychomotor retardation, I think this is just something that you likely see. Okay, then the final thing that you cannot miss, and it will really be very bad if you miss this out, okay, is suicide. First, you want to score their mood, okay? So ask the patient, can you rate your mood for me? So if the patient comes with sleep issues and they are positive for irritability, concentration, they've lost interest, you're already thinking, okay, this is depression, okay? So now you ask them to score their mood. So can you score your mood for me on a scale of 1 to 10? Okay, with 10 being the happiest you've ever been and 1 being the lowest mood ever. Okay, so you need them to score their mood and you need to specify. Don't just say on a scale of 1 to 10. Nobody knows what that means. the happiest, okay? And 1 being the saddest you've ever been. Now, any number, usually you're concerned about numbers below 5 or below 6, okay? Now, if your patient has low mood, then you have to ask about suicide, okay? And it's not okay to just say, have you thought of hurting yourself, okay? I'm going to show it, I think is on the next slide. Sorry, I just declared this. I think I wrote it down, so I don't. Yes. So always assess suicide risk. So when patients, so you tell your patients, like, sometimes when people experience low moods like you do, they do have thoughts of hurting themselves. Is that the case with you? Okay. Instead of just saying, have you thought of killing yourself or have you thought of hurting yourself? Okay. So you want to make it just look like you're just trying to be safe. However, you don't want the patient to feel awkward about it. Okay, so when patients experience low mood like you do, they do sometimes have thoughts of ending it all. Is that the case with you? They have thoughts of hurting themselves. Is that the case with you? So that's how you would assess for suicide. Okay, so that's how you ask for suicide. Then, so that's it in terms of that. Then when it's psychiatry, you may not so much follow PMAF-TOSA, okay? But there are certain things you want to ask for. What are things that you think you need to ask for in your patient with depression? What are important things? What are things that you think are really important to you? Anybody?
Trigger. What triggered the episode?
Yes, triggers. Thank you. So even from your data gathering, what triggered this? Was there any event that changed that led to this depression? Okay. All right, let me check the chart. Support system. Very good. Yes, absolutely. You want to ask about support system. Okay. Do you have any friends around? Who do you live with? Is there anybody that is supporting you? Okay. Coping mechanisms, very good, right? Are you drinking? Sometimes when patients have low mood like this, they tend to turn to alcohol. Would you say you do the same? Something like that, right? So you want to assess this. And for that, there is a mnemonic we call FAMISH, okay? So for those of you that are not familiar with that, so there is a mnemonic that we call FAMISH. So the F is you ask about friends, you ask about family. The F is not necessarily in depression, but the F might be more in your patient with schizophrenia, psychosis, or patient that abuse alcohol. You want to ask them, have you ever gotten into problems with the police? Have you ever gotten into legal problems because of your drinking? Okay, so again, remember that your substance use is also under this psychiatry counseling stations. Okay, so your patient that is drinking alcohol, you will cage your patient. You will ask about withdrawal symptoms. You ask about tolerance. Then you ask, do they have friends? How do they finance their drinking? Have they ever gotten into any problems with the law? Right? Then your A is going to be, okay, so if it's depression, then you ask about, do you drink, do you smoke? And by chance, do you take recreational drugs as well? Okay. Previous history. Yes, medical conditions that could cause depression, like hypothyroidism. So we are still on the FAMISH, okay? Then you assess the mood if you haven't done this already when you were gathering your data, okay? So in the initial part, when you were exploring the symptoms, so we're looking at a case where the patient comes in with sleep issues, okay? If you just did your SIGECAPS and you didn't remember mood, you remember with your FAMISH now, you can remember the mood, okay? You ask about mood, the M is for medication. So you still have to ask, are you on any kind of medication, including over-the-counter or supplements? Have you been managed for any medical conditions before or any mental health problems, okay? So don't say mental issues, okay? Mental health problems. Then insight, okay? You can ask the patient, how do you think we can help you today? Now, of course, your patients with psychosis would definitely lack insight, okay? So, I mean, they're usually out of touch with reality, but you can still just, ask, okay? Suicide, have you ever thought of hurting yourself? What about other people around you? Okay, so it's not okay that you all ask about suicide, you have to ask about homicidal risk as well, okay? So if they've had thoughts of hurting themselves or with other people. Now, if they say yes, do you just leave that question and jump to the next FAMISH? So if a patient says, I've had thoughts of hurting myself, what will be your next question? Anybody wants to try?
Any plan? Have you had a plan?
Thank you. Right? Have you had any plans? And also, is this something? Then if they've had plans, right? You ask when are they planning to do it, how they plan to do it, and have they ever tried it before? So it's not just enough to ask, have you thought of hurting themselves? Your patient says yes. And as far as they're concerned, you've checked the list. No, it's not enough. You have to explore it further. Okay. For everything that is a yes or yes, right? Any positive finding, try to explore further if you can. Okay. So suicide, any plans? How do you plan to do it? Okay. And is this something, have you done it before? So if they have plans, you want to ask, because if they've done it before, there is a chance that they might be more successful this time around. Okay. And you will not be safe if you let that patient, walk away without knowing that the patient is a high risk patient. Okay. So you have to check suicidal or homicidal ideations. Then hallucination, to be honest, you may not necessarily ask, just use your judgment as a clinician, okay? So just use your judgment. If you think it's absolutely relevant to ask about, do you see things when nobody else? Then when you're asking hallucinations, you can always, tell the patient, I'm going to ask you some questions that sound a bit strange, but please bear with me, okay? Don't just jump from, do you see things? Again, patient might be taken aback, okay? So imagine that you're sitting down and you're conversing with a real person, okay? So you don't just jump to, do you see things when nobody sees things, okay? Or do you hear things that nobody else hears? You want to use transitions, okay? In order to get that. But for depression, it's really up to you. If you think it's, you have to. Personally, these mnemonics are just there to guide you. They are not like 100%, okay? But they are, in a lot of cases, they are relevant, okay? In a lot of the cases, they are relevant.
Doctor?
Yes.
What about delusions? Because, manic depression and bipolar disorder.
Yes.
So do we ask about delusions, do you think?
You can, to be honest, you can. However, I feel like with depression, you will always know that this case is leaning more towards depression. However, to be fair, it could be bipolar.
Okay. Thank you, Doctor.
But for the purpose of OSCE, bipolar usually presents as maniac. Okay. Usually it's a maniac episode that brings them in. But what will not be forgivable is when your patient presents with mania, you don't ask about depression. Okay. Because you need to be sure if it's bipolar or if this patient is just maniac. Yeah. Yeah. So in psychosis, sorry, go ahead.
I just said thank you.
Oh, okay. Thank you. All right. Okay. So that's it for depression. So again, depression, you're asking about sleep, irritability, guilt, energy, concentration. Again, you must not forget anhedonia is one of your major criteria for patients with depression. Okay. For bipolar, patients usually will. All right. So let's discuss bipolar. What are the symptoms we expect in patients with bipolar?
Well, it depends. If it's mania first, then we ask about delusions of grandeur, of prosecution, excessive spending, inappropriate sexual actions.
Yes, that's it. Thank you. So those are the symptoms. So those are things you'll be looking out for. Okay. So usually your bipolar patient might present as patient that is not sleeping. Patient is only sleeping for 3 hours. In addition to that, patient will also have the delusions. Okay. So they might tell you that, I feel like I'm the king of England. Okay. So they would have those delusions. Then you now need to ask about hallucinations. Okay. So do you see things? So, but let me just write out all the same time. I think we mentioned delusion. We mentioned flight of ideas.
I think DIGFAST.
Huh?
There's a mnemonic, DIGFAST.
DIGFAST, yes. I was trying to remember it, but I don't even remember what DIGFAST is all about. The D is what again? The depression, right?
Distractibility.
Distractibility, thank you. What's the I?
Impulsiveness.
Yes, impulsiveness, right?
Grandiosity.
Grandiosity.
Flight of ideas.
Flight of ideas.
Increased activity.
Yes, increased activity.
Sleep deficit.
Yes, activity. Okay, sleep deficit.
And then I think talkativeness or thoughtlessness, basically. I think
Yes. So that's the T there, right? So they talk a lot. So they have I've forgotten what they call that speech. Somebody knows the name. There is a word for the speech. Pressured speech. Yes. Pressured speech. Yes. So they have that. So your patient is presenting with this, right? So even though you know this patient has bipolar based on their presentation, you can still ask about hallucinations. Okay. So do you see things that nobody else sees? Do you hear things? Now, if they see things or hear things, what do you want to do next? You explore.
Yeah, if they hear
things or anyone else around you.
Sorry, Dr. Olga, I didn't get you. Somebody was speaking as well. Tell me, Dr. Olga.
Is anyone else seeing these things as well?
Yes.
Is it only that person or someone else?
Yes. So has anyone else seen it? In addition to that, I want to ask the voices. Can you describe the voices to me? Yes, Dr. Mfon?
Yes, you can also ask, what are they saying to you?
Yes. Are they talking to you? The voices, are they talking to you? Are they familiar voices? What are they saying? Are they giving you any instructions? Okay. So you definitely want to explore these voices. Do they give instructions? What do they tell you to do? Are they familiar? Are they male or female? Okay. You might not ask everything because of time, but you still want to demonstrate that you're exploring. Okay. Then you also want to ask these voices, they instruct you because it's important. They may tell him to go and hurt somebody. Okay. So that's hallucinations. All right, then for psychosis, so that's bipolar. So we've talked about depression. We've looked at symptoms of depression for bipolar. And again, you cannot diagnose somebody with bipolar if you don't ask about depression. Okay. You have to ask, have you had moments of low mood? Okay. You have to ask. If not, your diagnosis is mania. Okay. So you have to be seen asking for depression. Okay. You have to be seen asking for depression. And of course, always ask previous episodes. Okay. Previous episodes. So don't forget that. Okay. All right. So we're going to go to the next thing. So psychosis. So we know that psychosis is characterized by hallucinations and hallucinations are what? Delusions.
Delusion.
Thank you. Right? So we know psychosis is characterized by hallucinations and delusions. Okay. So hallucinations, we ask, do you hear? Do you see? Now, delusions, you can ask about their thoughts. Okay. So I'm going to read that to you. How you can ask. There are three things. There is thought insertion, thought withdrawal, and thought broadcasting. Okay. So, but you need to know how to ask those questions. So, do you think other people steal your thoughts? Okay. So, do you think other people steal your thoughts? Thought broadcasting. Anybody has any idea what we would ask this?
if others hear their thoughts or
Yes. Do you think other people can hear your thoughts or ideas? Okay. So that way you are getting an idea of a delusion. Okay. You're getting an idea of your delusion. Then thought insertion. Do you think other people control your mind? Or do you think your thought is not yours? Okay. So you have to ask these questions. Okay. So thought withdrawal, thought broadcasting, thought insertion. To be fair, if you only remember two in exam, all well and good. But if you remember all three, but try as much as you can to remember all three. Okay. Practice with all three. Your patient with psychosis, after the patient says, maybe doctor, police is chasing me, or whatever the case is, right? Doctor, somebody's following me, whatever it is, you've explored that, then ask, do you think other people steal your thoughts? Do you think other people hear your thoughts? Do you think your thought is not yours? Then, have you had any thoughts of hurting yourself? Okay. Or have you had thoughts of hurting other people around you? Okay. Have you had thoughts of ending it all? Okay. So you want to ask this. Then ask them to score their mood. Okay. So you want to ask all these questions. So essentially, these are some of the questions you will see when it comes to psychiatry. Okay. So you're looking at depression, psychosis, bipolar. I don't have eating disorder here, but maybe in another time we can talk about eating disorders. Okay. Anorexia and bulimia. Okay. But if you look at that OSCE with mark scheme and you go under psychiatry, all of these cases that I put here, they are all discussed there, at least each of them. There is a case on depression, There is a case on bipolar. There is a case on schizophrenia. You know, psychosis is just when it happens within a month, right? Then schizophrenia is when it happens over 6 months. They're still the same thing, okay? So hallucinations, delusion. It's just that if it's happening over a period of 4 weeks, then we call it acute psychotic episode. But if it's something ongoing for 6 months, then we call it schizophrenia, okay? So you want to make sure that you do take note of all of this. So those are the possible things. And again, don't forget that it's not enough to ask about the hallucinations, delusions, and feel like, oh, you've gathered history, okay? You must still do your maftosa. But if you notice, instead of maftosa, it's FAMISH, but technically you're doing everything there, okay? You're just more psychiatry specific. Because think about it, you're asking about family history. You're asking about medication. You're asking about allergies. You're asking about substance use. Who do you live with? You're still doing the same thing, no? So if you feel more comfortable, like me, I prefer fish farm, to be honest, like fish farm, right? Fishes, who do you live with? Inside, suicide, hallucination, then past medical history, allergies, medication. That's actually how I prefer it personally. I don't, but again, I know that FAMISH is something that a lot of people are familiar with, but I like to do fish, okay? Then PAM, then I know that I still have to do my DESA. So that's how it is. Like for psychiatry, after you explore the symptoms, I will ask, okay, we have to get support, right? So who do you live with? But someone in the issue that probably asks about suicide, okay? Or what do you, if you see anything, okay? Is there any way you think we can help you? Then I ask you, do you have any medical conditions, any allergies, or even any psychiatric condition? But you don't say psychiatry, any mental health problems, okay? Yes. Any allergies, any medication? Do you drink? Do you smoke? You don't need to ask about diets, okay, and exercise, but do you drink? Do you smoke? Do you take recreational drugs? Okay, you need to know, because sometimes some people have substance-induced psychosis. So it will not be good for you if you don't ask about substance use. Okay, because your patient might have substance-induced psychosis, or it could just be psychosis that happened by itself without any known triggers. But you should be seen asking, you know, these questions. Okay, so again, find a way. This is just to give you an idea. You can arrange it the way it fits you, the way that you know best, you would not forget. Okay, so if you want to go with FAMISH, even there is another one, MC Mac Shit Farm or something like that. Right, so there are a lot of those mnemonics, but just find what works for you, okay, and ask all the relevant questions. So Mental Health Act, when do you use this? So it is a law in which a person can be admitted, detained, and treated for a mental health condition against their wish. So you let them know that, Mr. Jack, as you mentioned that you have thoughts of hurting yourself. You know, it's really important that we do keep you so that we can, you know, like to keep you here so that we can, you know, take good care of you. Because sometimes the sentence comes more in the role play. Patient may say, you know, somebody's chasing me. You know, that's so you can say something like, you know, we want to keep you here to keep you safe, right? Yes, I want to monitor you to ensure your well-being. Okay. Now, a patient might say no. Then in that case, you might have to use the Mental Health Act. Okay. So, but the Mental Health Act, and patient will say, no, you cannot keep me against my wish. You're not arguing with the patient. But you could say this Mental Health Act where, okay, we unfortunately, I know that you don't want to stay here, but because you're a risk to yourself, it's really important that we do keep you here, and we can do that under the Mental Health Act. Okay, so something like that. Okay, so I don't want to stay here, I have to go. You know, I'm really sorry about that. I know this is not where you intend to. I know you don't want to stay here, but I want to assure you first, assure the patient that the patient is safe. You know, assure the patient's safety. You know, I want to assure you that you'll be safe here, want to take good care of you. And the patient says no, then Mental Health Act. However, the way this case even came out in the OSCE with Mark scheme is you're talking to a relative. Okay, so the son was suicidal and they detained the son in the psychiatric unit. Then the mother is asking, why is my son detained? I don't want him here. So you have to explain to the mother, you know, that under the Mental Health Act, and I think it's 1983, but please confirm, okay? If you go to the OSCE with Mark scheme, it's there. Okay, when you go to the area where the checklist are, you will see the information there. Okay, so you need to tell them that. Now it has different sessions. I don't know why my spellings are. Okay, but so in case you're talking to a relative and say, oh, I need to take my son out, you can tell them that the Mental Health Act does allow us to detain for up to 28 days. Okay, however, you are free to appeal, and you can appeal within 14 days. Okay, so let them know that they can appeal within 14 days. Legal aid can be provided. Okay, so they can get support in getting a legal aid. Okay, so but they can appeal. When it expires, well, Section 2 cannot be renewed or enforced. Okay, so when it expires, Section 2 cannot be renewed or enforced. Then in that case, Section 3 might be enforced for 6 months. Okay, so Section 3 might be enforced for 6 months. However, one thing that is important is you let them know that you're only treating the mental health condition. You're not going to treat the patient's medical condition against their wishes. Okay, so let whoever the relative is know that, we're going to be taking care of your son. We're going to make sure that we keep an eye on him. We're going to be treating him, because he tried to, he did try to hurt himself. And because of that, we have to keep him here so that we could provide the necessary treatment for him. Okay, but let her know that she may say, oh, won't you shock him? You say no. For example, there are certain treatments, for example, electroconvulsive therapy, right? You cannot give that without patient consent. So let her know that there are certain invasive treatments that you will not administer, okay? But the goal is to keep the patient safe, okay? Always reassure them that the goal is to keep their relative safe. Your goal is to look after their relatives' well-being. And I tell you, if you say this nicely and you say this well, it will be fine. Okay, it will be fine. All right, so that's it for psychiatry stations. Then, so you might be told to assess mental capacity in a patient. So the station might be, Mr. So-and-so has been admitted. You want to do a procedure or a surgery, and the patient says no. The question says, assess the patient's capacity. Okay. Before we need to go in assessing capacity, does anybody know what do we mean by capacity? How do you know somebody has capacity?
It's checking their ability to make decision and
okay, so the ability to make decisions. Okay. What else?
Information.
To retain information. All right. What else?
Understand.
To understand. Okay.
And to use their understanding to come to an informed decision.
Thank you. That's it. Perfect. Right. Then they can make an informed decision. Okay. So they can make an informed decision. So I think of you. So a patient has the ability to understand, which we've mentioned already. They have the ability to interpret the information. Okay. So they have the ability to interpret the information. Then they can retain the information. Okay. And with that information, okay, they can make an informed decision. So they understand, they can interpret, they can retain the information, and they can say it back to you. Okay. They can say it back to that's the interpret. Okay. Then finally, they can make an informed decision. So if you get to a scenario and you're asking the patient, we need to do surgery to remove your appendix. And the patient is saying no. And you ask the patient, do you know why we need to do the surgery? And patient is just incoherent. Or patient is saying something that is not what you said. Okay? Then you know that your patient lacks capacity. So for stations of capacity, you must, of course, again, introduce yourself. Hello, I'm Esther Monday. I'm one of the doctors here today. Can you confirm the patient's name? They might be wearing a wristband, so you can confirm or ask them for their name and age. Explain what you want to do, okay? Explain that the situation is life-threatening, okay? So you're explaining. Then you ask them to say it back to you, what you just said to them, okay? Then explain the need for the patient to undergo the procedure. So first, mention that your appendix is inflamed, okay? if we do not treat it, your appendix could rupture. Okay, and if it ruptures, you could have very serious infection, which could potentially be life-threatening. Okay, and so for this, we need to do a surgery, and you need to explain the procedure, and patient needs to understand what the procedure is about. You need to explain the need to do it urgently, right? You need to tell them, we need to do this so that we can, ensure that this doesn't get worse. So you need to explain the need to do it urgently. Okay, then how do you know they have capacity? So the information that you gave them, let them give it back to you. First, do they understand it? How do you know they understand it? Tell them what I just told you. Can you say it back to me? Can you say what I just said back to me? Do they retain the information? So can they interpret that information? Do you know why we need to do the surgery today? Do you know what will happen if you don't do the surgery? Okay. Do you know why we need to do the surgery? Do you know what will happen if we don't do the surgery today? Do you know what will happen if we delay the surgery? Okay. So you need to ask those questions. Then the patient has to be able to communicate. And it's okay if they say no, as long as they have capacity. Okay. So if the patient understands everything that is said and they still refuse treatment, then you can say something like, is it all right if I ask my seniors to talk to you? Don't try to it's not a game of convincing, okay? The goal is not to convince your patient but the goal is to see if they understand the information. So if you know that the patient understands, for example, patient has cancer and patient doesn't want to undergo treatment, and you ask them, do you know what condition you have? Yes, I have breast cancer. Do you know what will happen if we don't treat the cancer? Patient says, yes, the cancer will spread. I spread to other parts of my body and I'll get worse. Okay. Do you know what treatment we're giving? Yes. Do you know what will happen if we don't treat it? Yes, I know. I would get worse. I'll be in pain and, I might die. And you're still like, is there anything we can do to make you comfortable? Oh no, I don't want the side effects of the cancer drugs. They are very bad. It's okay. So what do you think about it? Patient still says, I'm not convinced. I don't want to go ahead. Don't say, if you don't do this treatment, you may get worse and then you will likely die. No, obviously. I'm sure nobody's going to do that, right? Definitely. I even sound ridiculous, right? Saying that, but you'll be surprised, okay? Don't say, oh, if you don't do it, you will get worse, things will get bad for you. No. Let them know that it's okay. However, you can say, is it all right if I ask my seniors to talk to you? Okay. Then after that, if they still say no or they say fine, just let the patient know that if at any point you change your mind, please do let us know. Okay. Let them know that there is the option that they can change their mind. Okay. But this station is mostly about capacity. Then for distance, you ask the patient, right? Then afterwards, the examiner is going to ask you, does this patient have capacity? Yes or no? Of course. Don't just stop at yes or no. Give reasons why. Okay? Don't wait for them to prompt you. Does this patient have capacity? Don't just say yes and stand there. No, take initiative. Oh, this patient lacks capacity because, that would be the examiner's next question. But when you take initiative like that, it's really good. Oh, I think my patient lacks capacity because patient was not able to understand the information. Patient was not able to interpret the information. Patient did not really understand what I said. Explain. Give reasons why. Don't wait to be prompted. Okay? So examiner would ask you. Then he may ask you other questions like capacity, does capacity change and all of those. So, but again, OSCE with mark scheme as that this scenario in there as well. Okay. So go over it for that. Okay. So that's how you assess mental capacity. Okay. So make sure if patient is murmuring or they don't understand what you're saying, that means they don't have capacity. Okay. All right. So that's it for psychiatry. Psychiatry is not much, to be honest. The only thing with psychiatry stations is that they can be quite challenging, especially the psychosis ones, and it requires very good practice. Okay. Requires very good practice. But again, psychiatry could come in form of depression, psychosis, bipolar, mental health act, okay, So that those are ways, or eating disorders. Okay, so those are common scenarios that you would get for psychiatry. Right? So that's it for today. So next time we'll talk about counseling and breaking bad news. Okay. So next week, Tuesday, we're going to talk about counseling station and how to break bad news. Okay. So there is so those of you that are writing PLAB 2, you already know the spikes protocol. Okay. So but some people are not familiar with it. So we'll do breaking bad news and how to approach a counseling station. So on that note, do we have a volunteer that wants to take our first case?